Welcome to the Anatomy of Therapy. I'm Dr. John Cybulski with Bobby Riley. Today we are talking about the top 5 reasons your patients aren't getting better. Subsequently, reasons they are getting better, perhaps things that you're successful with. Maybe you hit one of these, maybe you don't hit one of these. Perhaps you're getting a lot and maybe there's just 1 or 2 things that you're missing. Hopefully today we can cover a couple of those. But I will say the mastermind behind this one is Bobby Riley, who is in Reykjavik, Iceland. Did I say Reykjavik right?
It's close. It's Reykjavik. Yeah.
So
it's pretty good.
Not bad. So where are we starting with
unless people don't like this, then I'm not the mastermind behind this.
Yeah, no, it came to you in a dream. It was,
yeah,
that's right. Well, we were kicking off on these.
Yeah, the list could be much more than 5, right? But tried to narrow it down, tried to make it finite in the sense that we could discuss some probably the most common reasons. So maybe I can lay them out and then we'll just go one at a time. We have the first one is kind of applying your treatment all the time. You have a specific way that you treat and you kind of lead with treatment, or you don't know how to vary the treatment in accordance with whatever is presenting in front of you. I think everybody is guilty of this to some degree. So that's not to sound crass, like it's you'll see, we'll come back to it. Number 2 is just plain wrong, getting the wrong diagnosis. Number 3 is underestimating the recovery demands. You could be overestimating as well, but more likely it's going to be the former.
Right.
Number 4 is treating pain when the problem is movement. This is, I think, a better way. Yeah, John worded this one when we were chatting, instead of the cliche of symptoms, treating symptoms instead of the cause, because that's easy to say. But and number 5, which we'll get into at the end more clearly so you understand what it means, patient sabotage versus self-sabotage or doctor sabotage.
And these are in no specific order. This is the most common now. There's no research to back this up. This is strictly from the genius mind of Bobby Riley.
And this is not taken off of a research article or anything. And yeah, the numbers are however I wrote them down.
Perfect. There's the first one that came to you. So like the first one, applying treatment, leading with treatment. What's a quicker way? What's a different way to explain that? I mean, the immediate thing that comes to my mind is every hammer sees a nail, or hammers only see nails, that sort of thing. Mm-hmm. I know that I'm guilty of. I have my favorite treatment things. Like I am freaking really good at occipitals. I can release an upper cervical really fast. And you got elbow pain? Let's check out that suboccipit. You know what I mean? Is that a fair assessment of?
Yeah. And like I said before, everybody is guilty of this to some point. You're trying to fix a torn ACL through manual therapy and exercise, and you get to the point where you need to repair that ACL. That is no longer within your wheelhouse because you don't have that skill. If you did, you could just keep going and, you could expand as far as you're capable. But the truth is we're just not that capable over broad enough spectrums. We just, we have to be, specialists, or you can be a jack of all trades, but you're never going to be world class at it. So, but the hammer hitting nails or only seeing nails is the easiest one to look at because we have clinicians that use one thing, right? They are joint specialists, right? They only do mobilizations. That's it. Or you have only rehab people, or you have only passive modality people. It's kind of like, instead of adjustments, they do e-stim and ultrasound and laser and infrared heat and power crystals and whatever else they can get their hands on.
Gotta get some power crystals. Jeez, sounds good.
Yeah, and if you don't, this is a problem I've always had, which is if you have one tool, the hammer, I don't even know why you need to do an exam except for to rule out red flags. Because if you're only going to apply a hit of a hammer, does it really matter? Does it really matter if you have the diagnosis right or not? If you're still just going to do the same A, B, and C with every single patient.
I think we talked about this briefly when we were talking about histories and exams and how people do this, but their exam questions, they don't know, are kind of leading the patient to a particular thing. Maybe you are aware, I'm trying to lead them to these Graston tools or whatever, but you should also know that if you are doing that and you really only have one or two treatment modalities in your back pocket, everything prior to that, if it isn't set up towards asking questions towards that, it should be, honestly. You better have a heck of a hammer. But even if you're unaware, which honestly, that's I think where I was in the first couple of years of my treating, where I was asking these questions and they may have seemed absolutely insane to the patient, because then I was asking these questions. Maybe I was going through my alphabet questions I learned in school, but then all of a sudden I applied this different treatment that had nothing to do with these questions. You know what I mean? And then finally somehow they kind of lined up and I was leading the patient there. But at some point, at least make sure they're in accordance. Hopefully that's the best scenario, or make sure your questions can also open up to your treatment, to a different any type of treatment, if that makes any sense.
Yeah. And I think, what kind of piggybacking off of what you were saying, if you can get some internal referrals to grow your practice as opposed to marketing to the masses,
Right.
That'll help too, because you're more likely to get in those people that you that you really helped, that you really, shook their world. So they want to send people to you. Chances are they're like similar patients, and that'll make your life a little simpler, because again, we all have a limited tool set. But one more little specific example would be, like I wrote down tendinopathies, and that's a tissue problem, and you may think manual therapy is the answer for that, and it's maybe fine to address the pain, but it is, or to give them some relief or help them sleep at night. But the answer for tendinopathies is not manual therapy. Sorry, but it is load. Yeah. There's nothing else you can do but load. So when you're applying, if you are a manual therapist, and that is what you're applying to each person who comes in, and somebody comes in with patellar tendinopathy, for example, it's just not, it's not directly going to help that tendon, right? If it's tendonitis, it's possible, but true tendinopathy, you need load. So it's just one more example of the specificity of applying your treatment matters.
No, that totally is fair. Yeah. I mean, ideally, again, if I could just say a little bit more clearly, your treatment, your questions that lead up, your exam that leads up, the test that you do, hopefully falls in line with at least the treatment, your hammer. So the questions all lead to the hammer. That would be good. There, of course, are diverging pathways where you just ask the typical questions, and then all of a sudden a hammer comes in and the questions don't match up with the hammer. In my perfect world, I would say that you would have a broad range of questions, and then based on the responses from those questions that are unique from that patient, you could take any number of different treatments to resolve the answers or problems that you found via your testing and your exams. Mm-hmm. To me, that's the best. Ideally, I need to know that I only have these particular hammers, these particular tool sets. And so my questions should hopefully be tailored into that direction. And then, of course, if I ask questions and I hear some things, then maybe I need to refer out that don't apply to my skill set. And honestly, I've won a lot of patients over that way, just being honest and getting them to the right place, getting them help, which is hopefully the ultimate goal.
Absolutely. Yeah.
Number 2, though, moving through these nice and quickly, we'll diverge here in a second, don't worry. The wrong diagnosis. So, I mean, diagnoses are tricky in the first place. There are some orthopedic tests that will match up, and there are some orthopedic tests that won't match up. Some history questions that'll sound like something, but the test won't match that. When you think wrong diagnosis, where are you kind of going with that?
Well, I think I fall in line more with the thinking of Stuart McGill when he says there's no such thing as non-specific low back pain. There is a reason for the low back pain. And I don't think he says this, but I often say this, even to patients. I say, you have a reason why your back hurts. The question is am I or anyone smart enough to figure out what it is? I think objectively, barring a very big psychosocial aspect to this, or you know what I mean, some kind of emotional trauma. If we just eliminate that for just a second, I think barring any of the extremes, there's an answer. It's not as objective as math. 2 + 2 is 4. But it's close. It's more of like it's a probability. There's a probability distribution. It lies in this part of the graph here. I can't tell you exactly if it's 2 or 3, but it's right in there somewhere. I think that exists for patients. The problem is we don't always know how to arrive at we can't get our probability distribution narrow enough to know where have a strong likelihood that it's somewhere in that area. So if you, by wrong diagnosis, it just means if you get the tissue wrong, like the specific tissue, ligament versus tendon versus muscle versus bone, that can cause a problem. You think it's inflammatory, but it's not an inflammatory issue, right? You think it's local, like it's a hip problem or it's a ankle problem, but really it's coming from somewhere else. It's a motor control issue. It's a weakness issue. You're getting the I don't necessarily mean it is, it is this exact diagnosis. It is Osgood-Schlatters. It is sending Larson-Johansson syndrome, right? I mean more of, which tissue is irritated, and you can attach some of the variables that are probably linking up to why that person is having that issue, right?
Yeah, I think that the importance of previously discussed history questions that we did, I think it was our, in telehealth one, where we were talking about making sure what it is not. Like you can rule out if you can rule out all the things you don't think it is, you can save a lot of time. Because like you said, it's really hard to get a pure, perfect, I know this is exactly, yes, you can kind of tell what tissue might be hurting. That's not hard. But in terms of, the diagnosis to go after a treatment, you could waste your time treating a lot of things that aren't really going to help a patient. And so ruling out those things that are not, getting those things off the plate, even back to your last point about the psychosocial, a patient thinks their injury is something. If you can tell them what it is not and get some of those, red flags in their mind off the plate, I think you have a higher success rate for sure.
Yeah.
Go ahead.
Well, what do you think a remedy is besides maybe, what do you say, approaching or treating and knocking out the negatives, taking away the things that it isn't? What else would you do for, to help somebody say, well, okay, how am I supposed to get the right diagnosis?
So great question. I mean, I would like to do these things a little bit more specifically in terms of like test, retest, test some sort of input. And this will go to our next point here pretty quickly. But if I can do a test and I say all the strain is coming from your lateral elbow, and I do Modleys and Cozens and elbow tests, and I can reproduce that a couple times, then I can say, okay, pretty definitively the extensor muscles are pulling on your lateral epicondyle, and this is the problem. Then if I can take away some of the tension from the extensors in whatever form or fashion that is, and you can even do that mechanically speaking, where they can move into the extensors, but they can do it passively or whatever. And you could take the pain away very quickly, then that is also kind of a confirmatory thing. One of the tricks with this is the quick test and retest is that some conditions need a little bit more time to actually heal. Like you were talking about tendinopathies and stuff. Like there are just some situations where you're like, man, this is going to take a month for full resolution. And so confirming a diagnosis can be very tricky in that sense. I'll say in terms of this another one I thought about is treating a bunch of the low-hanging fruit. So in terms of, we talked a little bit about this before in our running episode. If you haven't heard it, go listen to it. But doing a big stretch like a hip flexor stretch. If you work on generally opening up a hip flexor, you work on generally kind of letting go of the quads and a very big kind of area. When that person has those restrictions, you can start to take care of some things that may not exactly fix their sciatica or a little bit of a lumbar strain. But if you can kind of get these big areas around it, you can kind of also weed some stuff out. Like I was telling a doctor earlier this week, I was like, imagine in terms of these big stretches and big, foam roll every day, hang from a bar, kind of loosen up your shoulders, do some good breathing work, meditate every day. These kind of general things that doctors will throw at people. It's like if you see a wall and there are little divots in it. You got a white wall and there's a little patch here, there's a scuff up there. If you just go over and put a little bit of paint over those little spots, yeah, you'll clear out the scuff, but in relation to the entire wall, it still looks pretty unbalanced. So it might be a better first step to go over that entire wall, whitewash it with some of these bigger things. And this kind of goes back to our first, applying the treatment. If you apply a very specific treatment, you better be right. You know what I mean? Your rehab better be very, very right. Unless you want to go after these bigger things and get some of this low-hanging fruit, in which case sometimes you catch a lot of the little things. Does that make sense?
No, perfectly. I think it goes back to the probability distribution, kind of attacking this from a math perspective, or a graphical perspective, where you want to see this area under the curve not be across the entire spectrum. You don't want the area under the curve to be the whole graph.
Right.
You want to try to narrow that as much as you can. And that's what I mean by, you don't have to always nail the diagnosis, but by getting rid of all the things that it's not, you are taking that area under the curve and you're narrowing it. So you're starting to get a more focal point on that curve. So you say, okay, it's somewhere between -5 and 5. Okay. Right. That's just saying, okay, I'm just going to crack every joint in this person's body and we'll see if it works. Right. Or I'm just going to massage from the heel cord, the Achilles, to the top of their head.
Right.
And just see if their low back pain goes away.
Sure.
Right. But if you can narrow that thing to say, hey, it's from -1 to 0, or even better, it's just from -1 to -0.5. And you at least can say, yeah, I know they have poor ankle dorsiflexion. I also know they have poor hip extension. And I also notice that they just don't use, they're kind of weak on one side. So I'm going to work on those couple things, strengthen the other side. And at least you're giving yourself a good shot at doing, kind of attacking what John was hinting at there.
Yeah, absolutely. And we're going to get a little bit more to this one, and we get into number 4, and we can talk a little bit more about it. Anything else with the wrong diagnosis? Sometimes, going after having the wrong diagnosis, don't overstink it. Don't be a fart smeller. Do some things will work for the patient. Give them some benefit during your treatment. If you're like, is this SC, is this AC, is this the infraspinatus or the supraspinatus? We talked about stuff in the knee. Is this the pes anserine or the MCL? You can fine tune your palpation, but if it's medial knee pain, it's medial knee pain, and so don't overthink it too much. But I think going through number 4 here in a second will help us kind of clarify some things with this as well. Anything, left with that wrong diagnosis that we missed?
Well, I would just say, I wrote down improve your skills, right? And I don't mean improve your treatment necessarily. Think more foundational. I think, we bring up Bill Hartman often, and some, people ask him, what course should I take? Which cool thing, which tool should I get? And he's like, get a really good physiology textbook or get a really good neurology textbook. And I'm not saying, just go read textbooks, but improve your skills means, if you're not able to really feel confident about diagnosing, you're just always a little lost. Like, I don't really know. It's something with this. I don't know. Improving the depth or the range of what you can appreciate can help. So that can be continuing ed. It can be going back to the foundations and understanding physiology better. And me and you have been doing this for 10 years, and I'll go back and learn something that was basic and it reshapes my thinking again. I'm like, oh yeah, that's right. It takes this long for bone to turn over, or it takes this. And it's like something I should have known, or only the outer third of the disc has vascularization, or there's something, and it'll click back in my brain and say, yeah, that's why you're not getting this with that patient, or that's why it's taking this long, or
Right.
you know what I mean? Yeah. So just, yeah, that's all. That's
Focus
all
on one thing. No, and hey, I think that focusing on one thing is do the Benjamin Franklin method of self-improvement. There are so many things to focus on. And if you went over your day, you'd be like, I missed this, I should do this, I should have done that. You'll pick a dozen things out. Really pick what you think is the most important thing and do that for a week, do that for a month, and be like, I am going to be the best history taker, and I'm going to focus on that this entire month. Or I'm going to be so good at coaching a hip flexor stretch, whatever that might be. Pick that.
What are you working on right now, John?
What am
We're
I
so
working?
we're so didactic. I gotta put you on the spot here.
No,
What's your
so
one thing right now?
yeah, right now my one thing is trying to listen to patients a bit more, because I jump to conclusions very quickly with my patients. I'm like, I already have 4 ideas now about what I want you to do, and I think I sometimes cut people off. And so I'm going to be like, you know what? I'm going to let you go. It went against me. This one lady this week was just talking and talking, and I had to stop her a little bit. But I am really trying to let people speak their piece. What about you? What are you
Very
working
good.
on these days?
Well, I've been off, away from the clinic for a few weeks. So when I get back, I have been thinking a lot more about the kind of experience I give the patient, and balancing it a little bit more between what I think they need and what patients want. I think I do too much of what I think they need, and that sometimes you won't always connect very deeply with the patient, or it'll only be certain types of people. If you're wondering why Joe loves you to death and sends everybody to you, but then the next 5 people that walk in, are like falling asleep at what you're saying, and they don't make eye contact with you, and they don't reschedule. I think often, yeah, it's just too much focused on me. And I think that's a value I'm giving them. I'm saying I'm giving you everything I can to help you. But at the same time, that may not be why they came in. They may just want somebody to listen. They may want somebody to touch them. They may want to be adjusted. They may want this. So I'm going to try to listen to what they want and kind of give it, and kind of work that into the process.
Bobby and I have a mutual friend I think you spoke with him this week down in Houston, and I spoke with him, and he's a super, super smart guy, like really, really smart. And he's kind of I would say the far end of the spectrum, where he is just going to kind of force you into this particular thing. But I was saying that to him, he was like, what are you working on? And I was like, I am working on doing what I think the patient wants me to do, but then sneaking in a bunch more stuff.
Yeah.
You're like, I think you want me to crack your back, let's just say. I'll crack your back, but then I'm going to have to sneak in this breathing technique, or I'm going to sneak in this manual therapy to lead up to that back cracking, so that, or this foam rolling thing. And I'm going to wrap everything I want around cracking your back. You know what I mean?
Mm-hmm.
I think that's what I would say.
Yeah.
Cool.
It's solid.
All right. So point number 3, and there's a couple different wordings for this. So why don't you kind of go into this? What's our third point here?
I worded it as underestimating the recovery demands.
That's a good way.
Yeah. In another, in a simpler way, it just means like you think this is all the patient needs to get better. They just need your adjustments. They just need your manual therapy. They just need the Graston technique. They just need needles, and you know what I mean? Or even they just need 3 sets of 5 of clamshells every day, or, banded rotations for their rotator cuff issue. I think it has to be a high, in my opinion, very high. 90% of the time we will underestimate what they need.
Sure.
And it doesn't mean just because you throw 10, you know, I've seen patients, I'm sure you have, they've come to you after a physical therapist. I'm not picking on the physical therapist, but they'll come in with like stapled pages of here's all my exercises.
Yeah.
And I get this all the time, to be honest with you, from the physios or PTs when I was in the States, where did they just pull an exercise from every part of the body and give it to you?
Yeah.
There's no specificity to it. Like if the person came in and said, "Hey, I've never exercised. Can you give me something for every part of my body?" I would go, "Wow, this was well done on all these pages."
Sure.
But I mean, that's not what I mean by properly estimating or overestimating what the recovery needs. That's just throwing stuff at the person and hopefully one of them is right.
Right.
I mean, I think most issues take longer than we think. We think we deliver some extra magic from our hands or from our tools, and we do matter. I mean, I don't belittle anything that we do in person, but I think things take time. Hips to become more mobile take time. Tissue to get stronger takes time. This is why you rupture tendons when you go on steroids, because the muscles grow faster, but the ligamentous tissue, the tendinous tissue can't keep up. I mean, this takes time for these things to adapt. And what you did was you maybe have got them out of pain. And I think I've said this before, getting somebody out of pain is not necessarily fixing their issue. And if you never see that person again, you might not have fixed them. They might have finally realized, well, that didn't work, and they go try something else when it comes back in 3 weeks or 3 months.
Yeah, I think this one of the many ways that people miss this has to do, again, with a combination of the previous couple that we've gone through. Again, let's just pick on young me. I have these treatment tools. I'm just going to apply them until I think I've burned out all the gas in my tank. That's how long I think I need to fix your low back. Will that take me 5 or 6 visits? Basically, I'll be like, I've got 5 or 6 visits of tools to give to you. And if after those 5 or 6 visits, you're not better, then maybe we need to talk about something else. But for me, I'd be like, no, I still need to do that hip flexor release I learned I wasn't supposed to do. I forgot about doing the transverse friction massage that Bobby loves so much. Okay, cool. If I have a list of things in the back of my head, that's how long my treatment plan is, by the way. It was. Is my treatment plan perfect? Is this going to take, 4.1 visits? I'm hopefully better these days, but sometimes just being aware of why it is you treatment plan the way that it is you treatment plan, helps you become aware of what it is you're doing. My tools, I was like, if I can't get you better in this amount of time, my tools don't work. So that was my thing. I do think that we do underestimate, and I was still wrong. I didn't think about the specific loading of tissues, the specific change of a capsular change versus a bony change versus a neuromuscular global pattern kind of change. Like, how long do each of those kind of take? And I do think you're right in terms of getting out of pain, because one of the worst things that I've done in my career is get people out of pain super fast and not made the overall change that they need to stay better. So they come in, they see me, I get them out of pain, they leave happy. And then a day later, an hour later, as far as I know, pain comes back and they go, wow, geez. And what that does to the patient's psyche, by the way, is they go, A, I rely on John, and B, John didn't really fix me. He made me, he got me out of pain, but this pain is so bad that it came back right away. And I didn't do I didn't do well enough. I didn't do a good enough job of setting their expectations. Like, hey, we're going to get you out of some pain today. That's going to provide a window of opportunity where I need you to do X, Y, and Z. And I didn't set expectations very well in that sense. I was lucky enough that I had some good hands and I had some cool techniques, but if I could set them up for the roller coaster that they're about to go on when they come get treated by Cybulski, I think it would have been a lot more successful. But I lost a lot of patients because of that, because I got them out of pain so quickly. It was a problem. But what are some of the bigger errors you see in terms of,
Well, man, I'm with you. The expectations thing is so huge, and I thought of one as you were talking that kind of highlights this well, which is I see a lot of young gymnasts, anywhere from 10 to 18, 10 to 20, something like that. But the ones around, let's just use the example of the ones with Osgood Slaughters or patellar tendon issues, tibial plateau issues, or not plateau, sorry, enthesopathy, tibial tuberosity. You guys get me. So if I've done this before, I've done both of these, so I can just share each way. If I go in and I talk about, hey, I know what's going on. This is basically like a tractional enthesopathy. We need to limit that. We need to get it stronger, but keep that tissue lengthened. And I'll try to calm down the insertional site, things like that. And you should be good to go. Okay. And if I see them for 3, 4, 5, 6 visits, and then they're like, well, you told me all you had to do was these things and you're going to calm it down and I should be better. And those people start to fall off the schedule because they had an expectation that I was going to fix this. And then I've had other ones, this is like more recent, where I say, hey, you gymnasts are nuts. You guys train 4 hours a day, 6 or 7 days a week. My job is to keep you alive. That is it. This is how I talk to them now.
Sure.
I say, chances are, and you know the thing like undersell and over deliver. Okay. It's kind of like that, but it's really a bit honesty and a little bit of that, which is, hey, chances are I'm never going to get you out of this problem mid-season. You guys train way too much. I'm going to try to keep you in the game the best I can. Everything I'm going to do is going to try to keep that thing from getting worse, stop you from getting a huge knob on your knee so you never can kneel as an adult ever again. And just let you get you through the season. A little bit of pain is okay. Make sure you keep it in these pain ranges, and that's fine. A 3 out of 10 is fine. A 5 out of 10 is not. And voila, those patients love me. The moms love me. They still trust me. They still bring them in, and they're still, they love me at the same time as they say she's in a lot of pain today, as opposed to that look like they want to stab me. She's in a lot of pain, and you said this shouldn't be a problem. You see, right. just that. It's just the treatment could be the same, everything could be the same. Two totally different outcomes.
Yeah, that's 100%. That's a way better way of saying what I did more specifically. I mean, casting that wide net to be like, look, as I treat you, these number of things can happen, and giving yourself some wiggle room to be like, look, I can't make you perfect. Okay. But if I can get you to move a little better, would that be a win? If I can get you to feel a little bit better for a second and give you some things to work on, would that be a win? Absolutely. And giving them just a little bit of hope. And then honestly, in there, a lot of times you do get a much bigger win, as you said, under promise and over deliver. Give yourself some wiggle room. Don't hem yourself in being like, okay, today you walk out of here, no pain, you'll never feel it again. You're just setting up a situation where, your success rate is going to be not very high, honestly. Mm-hmm. Cool. Yeah. Number 4, this is one that I think about this one a lot, to be quite honest. Treating pain instead of movement. And we've, gone back and forth with this before, but there are a couple different ways to say this. There's Perry Nicholson out there is the guy that says, stop chasing pain. There's the Carol Lewitt quote that people like to quote all the time. He who treats the side of pain is lost. And, when you first hear these things, you're like, oh my gosh, that's right. The body's all connected. I do need to do visceral manipulation to make sure that the lymph is flowing and that their knee pain does stop. It is good to consider a wider berth of things. However, treat the side of pain. This is going back to earlier what you said about, I want to try to make sure that I fall a little bit more in line and giving the patient something. I feel like a lot of times when I was younger, I could fix a low back and never touch a low back. I can make your hips move better. I can make your thoracic rotation better. And I could just completely leave your low back alone, not put my hands on it, not palpate it even. And I bet, like I would put money down, I can make your back feel better. Now, in terms of what a patient wants, that's not good. That's me showing off these fun, weird techniques that I've found and figured out and worked on. But it doesn't, but the patient wants you to work on their back. And a friend of mine said, I work on necks so that people think that I work on their neck. But a lot of necks aren't necks. You know what I mean? And so in terms of treating pain versus movement, what's another way to kind of say this? I know you had another, I almost like the wording of yours better, to be quite honest.
Treating pain when the problem is movement.
Yeah, there you go.
Yeah, I mean that was your wording.
Okay, never mind.
I took it away from the cliche of treating symptoms instead of the cause, because everybody believes they're treating they're treating the cause, not the symptoms. And okay, sure, I think we're all to a degree trying to do that, and at the same time not doing that, not accomplishing it completely.
Right. No, I mean, yeah, don't bash Western, quote unquote, Western medicine because they treat symptoms. We all do that, and it's necessary at a very high click. But this goes back to my painting the wall analogy. You don't want to just patch up that little thing when the whole house is kind of fallen down. Don't be surprised if that water just keeps dripping and causes a hole there again. But let me give you a kind of a bigger kind of example. We've been a little bit too abstract with this. Let's just say, and this will go back to what we were talking about earlier. You mentioned treating a tendinopathy, and if you treated a tendinopathy.
Or when I read your line, I actually thought of like impingement of the shoulder, right? Where the problem, you say treating pain instead of movement, where the pain site is the shoulder or the supraspinatus insertion in the front, but the movement problem is impingement, or it's scapular motion problem, or a thoracic problem, or you know what I mean, or breathing or rib cage problem. It's treating the pain will just get you, a little bit of, give you a little bit of time before it comes back. But it's you're just stuck in the mud, spinning your wheels. You mentioned one about the knee as an example.
Yeah, I mean, back to the medial knee episode. We treat the medial knee and we get some things to relax around that medial knee joint and perhaps take some pain away and just passive flexion and extension of the knee or something like that. But then they go and they do a squat, and they load up a squat in the box, and then the pain comes back. So we treated that local side, but there was something distal to it. There was an ankle that was weird. There was a hip that was weird, that was causing some external torque onto that knee. And you just treated that side of pain, but not that more global movement. Now, I do think there is a ditch on the other side of the road where people only treat more global patterns, and they ignore some of that small tissue stuff, right? And they may just be like, well, just ice the inside of your knee. There's no need to address that. What we're going to work on is hip extension, hip interrotation, abduction, the general movements of the knee, or even larger patterns. There are different groups of people out there. You think about the SFMA guys or FMS. There's the hip flexion pattern. There's the squat pattern, the triple flexion pattern, and there are more nuanced patterns out there as well. But sometimes only treating those big patterns, you can catch a lot of the small stuff. But then again, you got to go back to what Bobby was talking about in terms of time. How long do these bigger patterns take to offload that smaller area of the symptom?
Yeah, for sure. I even think when you might even have it right, but it just, things take time to change. It takes time for water to smooth a rock out. It will do it, but it takes time.
Yeah, absolutely. There are some fun global, I do love this one so much because it does start to explain a lot. If you do work kind of globally and you're ultrasounding that medial knee and you're like, okay, we get the pain to go away, but it keeps coming back. I think as a new doctor, as a new clinician, when you do start to catch some of these larger patterns, and you can see how there are other factors wielding into this pain, I think that's very powerful to kind of start to recognize. The hip extension pattern, the lack of dorsiflexion, and being able to explain how your ankle everting or a heel, an arch collapsing can affect that medial knee, because it's not that obvious as soon as I wasn't taught that in chiro school. I don't know if there are some wonderful schools out there now that are teaching this. I've seen videos where I see, a femur and a tibia, and there's a foot pronated in and a knee going in and a femur going, but no one really kind of explained that to me until years and years. I don't know, when did you kind of pick up on the larger patterns of human movement?
Yeah, several years after graduation.
Yeah.
Still today.
Yeah.
Still today.
Last week.
That's what I study right now. Yes.
Right. It's tough, man. What was your? I want to ask you this. I'm kind of interested in this. What was your first kind of aha moment when you were, say, treating and you were alerted to or had some success seeing these larger movement patterns? I'll tell you mine while you get to yours. When I first started, people talked about Dr. Yonda with his lower cross syndrome and his upper cross syndrome, and that was kind of pretty well known. And I was like, those are kind of general. You get the slouchy thing, or you get the hips kind of opened up in the overextended back situation. But I was like, what is the deal with this Yonda guy? There's got to be more to him than that. And I went up and I looked some old articles. And as I was searching for Dr. Yonda articles, I found this guy, Gray Cook. He seemed to have a lot of similarities and paths kind of crossing with Dr. Yonda. And basically, Yonda has some great articles out there that can get very, very technical. But Gray had kind of put it in simple person, Tennessee country boy terms. And I love that guy. And so he broke out some of those patterns, and I started doing it to myself, and I started noticing it everywhere. And I just remember very clearly one patient, I was having trouble with their back, their low back pain, and he had pain reaching down to touch his toes, simple flexion. And I just went through the FMS, and I saw the major pattern that was restricted was his cervical flexion. He couldn't get his chin down to his chest. And I was just like, all right, whatever. I'm just going to work on this guy's neck, and I'm just going to see what happens. And I worked on his neck, and he was able to then touch his toes after that. And he was like, my back doesn't turn. And I was like, oh my gosh, there's got to be more out there. But yeah, since then, I'm still figuring out these patterns. They can get more and more intense. What about you?
I don't think I had these great epiphanies, but it's been more of like a linear growth. But there's some things that, because you're putting me on the spot, I did not get this question earlier, that just popped into my head. Yeah. And two things that popped into my head. One's a little weird, but there was a research article that showed after somebody had a bad burn or a terrible cut or damage to their face, and they needed plastic surgery to repair that damage from the fire or whatever it was. Sometimes they would because they had to, they would remove it's called a corrugator supercilii, these little guys just on the inside of the brow. And they realized that in populations that had a history of migraines, that also happened to have these traumas happen where just because of the trauma, they had to remove those muscles. Many of them, their migraines never came back again. And they found a link between that muscle and migraines. And I was like, okay, this is very strange. It's the same reason why we don't, the gallbladder refers pain to the right shoulder. Like, I don't really know why. Maybe somebody does, but I don't think we know why. And another one I just thought of was just getting stronger overall fixes a lot of problems. And I noticed this with myself first, where you have maybe a back pain or a knee pain. And as long as the training itself doesn't exacerbate the issue, it often can be your answer. And just you get stronger, you get more fit, a lot of these problems go away. Now, with that comes some of these overuse injuries where people get the nagging heel pain or the nagging knee pain from all the squatting they're doing. But that general pain, low back pain, these non-specific pains that McGill hates, a lot of those clear up. You know what I mean?
Absolutely.
So,
yeah, 100%. No, there's that's a whole nother podcast, I think. reasons why you get better by not directly going after the pain. Maybe we'll do that one day. All right. And the last one is Sabotage, my favorite Beastie Boys song out of all. What do you mean by who's sabotaging in this situation?
I grouped them. I grouped it into the same the number 5 being patient sabotage, and the clinical, your own sabotage, clinical sabotage of yourself. So with the patient sabotage, that's where they're sabotaging their own recovery. They're just not doing what you're telling them to do. And you could really beat yourself up on this and say, well, then I'm not connecting enough with the patient. I'm not expressing the importance that they do what I say. But in all honesty, you could have done everything right. You can have great bedside manner. You can connect with them. You can really care. You can stay up at night, can't even sleep because they're not getting better. And they may be still just sitting on that couch watching Netflix all night long with their big disc herniation that you're trying to fix. You're trying to help them, and they're just not helping you out. You know what I mean? They're not putting the sets in. You tell them, this is why I tell my patients, if I give you 5 exercises, you'll do 0. So I'm going to give you 1 or 2, and maybe you'll do it. Now we all love the patients that are like, give me more, I'll do anything you say, but those are few and far between. So yeah. And then the other one would be self-sabotage, which there's many ways I can think about this. I initially wrote it down as like, it's outside of our scope of practice, and we're still, or you can say outside your scope of practice, or even outside your individual scope of knowledge at your point in your career. So you just got out of school and you really feel overwhelmed, and you just keep the person there. They're not getting better. You have good intentions, but you're trying everything you can, but it's not working. But it can be any aspect of where you are your own enemy in this scenario in preventing the patient from getting better, because you either don't have the skills, you're in denial that you have the skills, and so forth.
No, that makes a lot of sense. I want to go back to that first sabotage, the patient saboteur. I thought all my patients, I was the second sabotage one, and I thought all my patients were sabotaging me. And I was just like, patients just don't like me. Like, you guys don't want to get better. You're coming here, but you actually don't want to get better. It's your fault. And we had Dr. Askey on previously, and I worked next door to him for years and years. And he was like, it's an 80-20, man. 80% of these patients are getting better. 20% of these patients are a bummer. 20% of the patients just aren't going to do the thing. They're going to not listen to you. They're just going to want a miracle cure, and then that's it. But he's like, 80% of the patients, if they came into your office, likely they want to get better, and there's something you probably need to improve on. There's something you're kind of sabotaging, you're missing, and that sort of thing starts to take time. You need to figure out. You need to, like I'm working on this week, is listening to patients and trying to find that one thing that would be a win for them, and see if your skills and their need kind of match up. And then, niching down and finding those patients that like you, where your skills and their needs kind of do align. Maybe it's more football players versus hockey players. But I do think it is more of an 80-20 thing where, there are just 20% of the patients are just going to cancel for no reason. They're just like, I'm busy, I don't really care. They don't have to like you. They just don't like the cut of your jib. You just look funny to them. They think you got a face they want to punch, just for whatever reason. People are a bummer. But I do think 80% of the time it's probably something that we can work on. And even if it's not, some of those difficult patients may awaken something in you that you were previously unaware that you need to work on, but you can work on it. I would say initially be a little bit more self-reflective on what it is you can work on. And then secondarily, go ahead and blame the patient, because you can't really control the patients, and you kind of have to let that go, which is where you were kind of talking about. I think you said something, I actually stole it, and I've been using it quite a bit. You said, if you do this exercise once, then do it none. I need you to do this exercise every day. I think this was with the Mashad toe thing, but I'm like, it's tough though. The sabotage is real.
Yeah. And like I said, there's many aspects that we could go into this, but you can self-sabotage yourself with your own marketing, for example. Um, John and I used to follow a particular page on Instagram, and I remember their thing was, we don't see anybody if you haven't gotten better for at least 8 months and seen 20 other people. Okay, so we can laugh at that, but I can give him a little credit because he's at least marketing to a specific demographic. If you are, I'll take anybody who walks in this clinic. I don't think it's going to be 80-20 as Nick suggested. In your guys' area or in where Nick works, I think he might have a good marketing strategy, and they know their audience. And 80-20, I would probably agree with him. It's kind of like a Pareto not disposition.
Disparity.
Distribution.
Distribution sounds a lot better. For
For
sure. But yeah, I mean, generally, when a patient does come into your clinic, they've probably checked out a couple other people already, and they have already filtered themselves out a little bit, you know, and the company that we work for has obviously worked on some SEO and our marketing and all that stuff. So they've already filtered down a little bit. And then within that even filtered down range, yeah, maybe it does go to an 80-20, but it's not 80-20 for every single person, you know, like but yeah, I do think this is a mistake that a lot of chiropractors, PTs, physios do make, where they're like, bring them all. I'm going to help everybody. I'm going to do it all. And maybe you can help a lot of people a little, but you can help a little people a lot. And and this goes kind of down to the social media thing, like people that are niching down into these very small groups, like the knees over the toes guy. How specific is even that screen name? And obviously it's kind of a jumping program and a stronger knee thing, but how specific has he niched down? And he's doing great. I mean, don't be afraid if you do know that you are the knees over the toes guy, that is your market, and you can find some people out there. There are some weird things on the internet, y'all. And I mean, find your weird thing and embrace it, basically, is what I'm saying. It's nice to be like, yeah, anybody with a pulse, come on in, I got you. But if you could knees over the toes guy, God bless. You'll do a lot better, I think.
I mean, if you're in this business because you want to help people, and you really like solving cases, but you're marketing to work comp and auto accident cases, which means I'm not saying anything bad about those people, but sometimes there is a monetary incentive to go that route. And in that case, that's fine. But if you are trying to solve every case, you may get a lot of people coming in that are not so interested in being solved. You know what I mean? So that disconnect can be terrible. Yeah. And closing down on what you're passionate about will help by itself. I mean, like you said, niching down. There's a girl that I know that only does gymnastics, right? That's very popular. I can't remember her name right now. Popular. She has to love her life. You know what I mean? Like, that is all she cares about. She can spend all day long with these gymnasts, and they know, you know, she's serious about it, and vice versa. Yeah. And if you don't have that, I mean, you're self-sabotaging your own clinic right there again, because you're not advertising towards the clients you seek.
Yeah, I'm glad you said that. I have one more thing. I heard, I was watching television during this quarantine, which is something I know nobody can relate to. But I was watching, my wife and I were watching the new season of Top Chef. And on Top Chef, they had like sisters or spouses or mothers come in, and they had to like cook with them, basically. So you've got these like world-class chefs, and then you've got their significant other, you know, roommate or something like that, who may not be so world-class. But yeah, and so there's this one guy on there, Brian Voltaggio. He had his sister, who was a pastry chef actually, came on, and he was being interviewed, you know, while everything's happening. And he's like, okay, you do this, I'll do this. And he was just like, you know, and he said this one thing and it stuck with me. He's like, I gave her something that she would be successful at. And I was like, man, I know that is such a great statement. I was thinking about that all week with my patients in rehab. Like, there are a lot of great exercises. If I could make 90% of my patients come in, be good at heavy deadlifts and front squats, you know, I would. But that's not going to work for a lot of people. I need to give them something that they're going to be successful at. And hopefully I have a repertoire that's wide enough where I can be like, here you go. Can you just peel these potatoes? You'll be successful at this and you'll feel better. Hopefully those two meet up. But that was a big one for me. But anything else before we close out?
No, I like that. It's totally an aside. I'll speed it up real fast, but it reminded me of a guy in Iceland who was very heavy. I mean, 450 pounds. And I kind of had this heart to heart with him, you know, and just said, hey, like there's probably some real pain coming from different sites in your body. And I don't know if I'm good enough to solve them, but you can help yourself out instantly, but we just got to get you down in weight. And he said, I've tried everything. If you got something I've never heard of, please tell me. And I said, well, I've had success with intermittent fasting. And he said, what's intermittent fasting? And it was just one of the things he hadn't been shown yet. And now it doesn't mean that works for everybody, but I mean, I almost get tears in my eyes when I think about this guy, because I saw him a few years ago before I moved to a new place. And I saw him, you know, as he was just starting that journey, he was like, I'm going to try it. And then I saw him on Facebook down 20 kilos and then 30 kilos and then 40 kilos and then 60 kilos. And then he bought a road bike and then he had a helmet. And now he was taking his daughter cycling with him. And then it's been 4 or 5 years now. And I still see him on the intermittent fasting Facebook pages, posting his updates, posting him cycling. And it's nothing that I did, but I approached him orthogonally. You know, I approached him at an angle slightly outside of what he had been approached with so far. And for that particular individual, it stuck. Yeah. And when each patient, you may have a home run that's available to you that works for that person. Doesn't mean you're ever going to find it, but it's amazing when you do. But if you only are, you know, you have your glasses on and you're looking straight at one spot with only can see one color, you're going to miss these chances. And again, it's not, you know, that case was kind of extreme. I don't get that all the time, but it was, yeah, I just love that example because it just highlights the uniqueness of the individual. Or even I mentioned that muscle in your underneath your eyebrows that can take away migraines. I mean, you're not going to solve that problem. This is where it's okay. You're not going to fix everybody. There's some weird things that can solve somebody's problem that is adjacent to what you can do.
That's awesome, man. I think that's a perfect way to end. Thank y'all for listening. Tell a friend. Find us on YouTube. Find us on Instagram. Find us on Twitter. Share it. Like it. Put it on a plane and take it behind the thing. Thanks for listening. Later.